and get started and maybe leave the QR code up for people to scan while I introduce our speaker. I'm Naomi Laventhal. I'm one of the faculty ethicists in the Center for Bioethics and Social Sciences in Medicine, and I'm the co-chief of the Research Ethics Service with Kate Spector-Baghdadi, along with being one of the faculty ethicists. And it's my pleasure today to introduce our speaker, Dr. Erica Andrist. She's a friend and colleague of mine in pediatrics. She obtained her undergraduate and medical degrees in her home state of Wisconsin at the University of Wisconsin in Madison, and did her pediatric residency at the University of California, San Francisco Benioff Children's Hospital. She then returned to the Midwest for fellowship in pediatric critical care medicine at Cincinnati Children's Hospital, after which we were fortunate to recruit her here to join the pediatric department and to work in the pediatric intensive care unit at our own C.S. Mott Children's Hospital. Since coming here, she has obtained additional training in the form of a master's degree in bioethics at Harvard Medical School, which she completes this month. In addition to caring for some of the sickest patients in the Children's Hospital, Dr. Andrist has established herself as a clinical leader in our institution in the domains of extracorporeal life support, which most of us call ECMO, and palliative care in the critical care setting, and is emerging as a national leader in pediatric brain death determination. She's actively engaged in all aspects of the organization's mission, supporting house officer education initiatives and mentoring fellows in their research and career development, and serving the hospital in vital areas such as hospital visitation policies and patient restraints. In her scholarship, Dr. Andrist has focused on disparities in pediatric critical care delivery and complex decision-making surrounding discontinuation of extracorporeal life support. And the topic of her presentation today, which is also the topic of her master's thesis, is about the ethics of quitting for clinicians. Please join me in welcoming Dr. Andrist for her presentation.
Wow, Naomi, thank you. I am really excited to be here today talking about some of this work. I do want to start just by making a small note. I put MD and MBE in my credentials here because today is actually graduation day for the Master of Bioethics program, so it seemed legit now to go ahead and put that on there. But as Dr. Leventhal mentioned, this is work that I did for my master's thesis for this MBE degree, and I am really excited to be here sharing the beginning of this work. As you'll see, I hope it is just the beginning and not the end of this work with all of you here today. Before we get to that, I do have a couple of disclosures that I want to make. Naomi already made one of them for me, which is that I have a leadership position as the co-vice chair of the Society of Critical Care Medicine's Contestation of Pediatric Brain Death Determination Task Force. That's a leadership position only. I do not receive any financial compensation for that, but it is a professional role that I hold. And the second disclosure is just something that I want to note before we get started. There are some curse words in this presentation, which is perhaps a little bit less common for an academic presentation, but I'm going to share some qualitative data that I think is pretty powerful, and I wanted to leave that in its pure and unadulterated form. Certainly understand, though, that some folks are not interested in that particularly in a setting like this. So I wanted to just warn people in case they prefer to depart, given that there will be a couple words peppered in there that people may not be used to in a grand rounds. But with that, we will get started. So the Great Resignation, as it's been termed since the years starting after the COVID-19 pandemic, has not spared the health sector. The New York Times estimates that 16,000 physicians have quit their jobs since the pandemic started. And among nurses, that number tops 100,000. And the scary thing is that these statistics are actually 6 months old, more than 6 months old at this point, so likely higher now. Simultaneously, though, the pandemic has reinvigorated discussions of the clinician's duty to care. And the duty to care is a unique ethical and legal responsibility that clinicians have to place the needs of patients above their own interests, including sometimes even at risks to themselves. If this duty is real, then quitting might not be ethical, especially during a pandemic when the increased demand is going to exacerbate the resultant staffing shortages and potentially compromise patient safety. But if that is the case, then all of these things become necessary and justifiable in the name of patient care, and the clinician really has no recourse. That also seems wrong to me. And so for my master's work, I set out to reconcile this problem, and we're going to talk about some aspects of this work in this presentation today. Our objectives are going to be to review the ethical justification for the clinician's duty to care. We're going to assess both clinician and public attitudes toward the duty to care in the literature. And then in my original work, we'll examine why a sample of clinicians quit their jobs during the Great Resignation before finally evaluating some of the knowledge gaps that still remain in order for us to truly reconcile this problem. I'd like to start by actually defining the duty to care. One of the things that really was most surprising to me as I embarked on this project is how many people out in the literature talk about the duty to care without actually defining it. They just have assume that we all have this colloquial understanding of what the duty to care is as they analyze it. But one definition that I like and that I've already alluded to is from David Orentlicker, who's a MD-JD, who wrote in 2018, "The duty to care is the duty of clinicians to place the welfare of their patients above their own interests." Put more precisely in ethical terms, the duty to care is a special positive duty of the clinician to both the patient and to society. What does that mean? Well, all of us have positive versus negative duties to promote the well-being of others. Positive duties are those things that we should do to promote the well-being and happiness of others versus negative duties, things that we should refrain from doing in order to avoid causing harm to someone else. We all have these general duties as citizens of the world who coexist in a society with other people, but they're not unlimited duties, right? Put differently, we're not obligated to give every cent that we have to charity to promote others' well-being. We're not obligated to go out and donate both of our kidneys to save 2 lives. These might be morally laudable things, maybe not donating both your kidneys, I suppose, but beyond some threshold of minimal risk of acceptable discomfort, they become supererogatory duties. There are, though, some contexts in which some people under certain circumstances might have special duties above and beyond those general duties that we all share as good and moral people. And one of those is the duty to care. This is put really strongly in the 1847 Code of Medical Ethics for the American Medical Association, which says that when pestilence prevails, it is the physician's duty to face the danger and continue their labors for the alleviation of suffering, even, and this is the important part here, even at the jeopardy of their own lives. So the amount of risk that the clinician, the physician in this case, was expected to incur was really potentially quite high, at least per the Code of Medical Ethics in 1847. But what justifies this duty? What justifies these special positive duties that clinicians have towards patients and to society? Well, one argument is that clinicians have special training, which makes providing care safer for them compared to the layperson. However, in an argument that comes from Heidi Malman colleagues in 2008, the key part about special training is not that it actually changes the moral duty that we have, it changes what the minimal risk of performing that duty is. So a really illustrative example here might be the case of personal protective equipment. So we can consider that in this context. So clinicians have special training, right, that makes it safer for them to provide care in times of pandemic. We have an advanced understanding of disease transmission. We're specifically trained, we're specially trained in things like how to don and doff PPE. This training makes it safer for us to provide care to individuals who have these needs in times of pandemic. However, what happens if there's no PPE? How does that special training then obligate us to take the additional risk that would be associated with providing care without that PPE? Malman colleagues argue that it would not. It's not the duty that changes, it is where the threshold for a minimum risk that changes. Perhaps though we can look to other arguments that justify the clinician's duty to care. Another is that clinicians consent to taking risks in providing care. They take oaths that say we will dedicate themselves to the needs of our patients. There's problems with this as an argument to justify the duty to care in an unlimited way, though, too. One is that oaths are variable. In fact, most medical students no longer take the Hippocratic Oath, the original Hippocratic Oath. Many medical schools write their own oaths, so the content can vary between school to school and even between year to year. Additionally, informed consent has very specific requirements in medicine, right? The risks, benefits, and alternatives are not discussed. And so the oaths that we take are not equivalent to true consent. Finally, consent can be withdrawn at any point, but the clinician's consent isn't readdressed at any point in his or her career. It might well be the case that a 24-year-old who is graduating from medical school or nursing school consents to risks that might be associated with providing care. But what happens as that clinician gets older, gets married, has kids, develops a chronic illness, starts to take care of their elderly parents? At any point, this might change the balance of risks and benefits for the clinician, thus altering their willingness to consent, but that consent is never revisited. And one of my favorite arguments, we can look to an argument from virtue. The good clinician is virtuous, and a virtuous clinician places the needs of patients above his or her own interests. I think this is really intuitive for a lot of clinicians, right? None of us go to medical school or to nursing school expecting that we are going to live lives that are just full of rest and relaxation, and we will never have to skip lunch, and we will always be able to spend holidays with our families. No, we don't expect that, right? We expect and we agree that sometimes our patients' needs will come first. However, when we look at virtue ethics, a really very cursory examination of virtue ethics reveals that not only does an argument from virtue not require a clinician to take all risk in caring for patients, it actually explicitly disallows it, right? If virtue is the mean between two vices, and courage specifically is going to be the mean between cowardice and rashness, then the nurse who charges into the Ebola ward without PPE isn't virtuous, right? She is rash, she is being irresponsible. And so there is some limit to the amount of risk that even the virtuous clinician is going to be able to reasonably take. And also, as a side note, looking at pandemics throughout history, as early as smallpox in the 1600s, all the way up through the HIV/AIDS pandemic in the 1980s, history would indicate that virtue is really not sound pandemic planning. Relying on people to do the right thing in times of crisis really places a lot of people at potentially unnecessary risk. So we might want to look to other arguments in order to ground this duty to care. One of those potentially could be codes of medical ethics, right? The American Medical Association, rather, the code of ethics that I alluded to at the very beginning, says that clinicians should put the needs of their patients first, even at the jeopardy of their own lives. However, codes of medical ethics change over time, and that quotation from the code in 1847 no longer appears in the American Medical Association Code of Ethics. Additionally, not all medical professionals are bound by the same codes. The AMA applies to physicians, but what about nurses? What about respiratory therapists? So these codes might vary in what is expected of their medical professionals, even as they're all asked to take care of patients during a pandemic. Finally, we have the argument from reciprocity, which says that because of the high salaries and social status that is placed upon clinicians, society reasonably expects to receive healthcare in return, especially in times of crisis, like a global pandemic. This is a reasonable trade-off that clinicians should respect. However, not all clinicians enjoy the same benefits, right? There is a notable difference in salaries among different types of healthcare providers. And there's arguably differences in the medical hierarchy as well, in terms of power, in terms of status and respect, even though people are taking the same risks and maybe even are taking differential risks. Those with less power and status are taking more risks in terms of time spent at the bedside in many cases. And then the question becomes, are these risks truly reciprocal if the cost is actually the clinician's life? So my take from this, and your take certainly may be different, but my take after thinking about all these arguments and reading what is there in the literature is that there is a duty to care. But the minimum that is required of clinicians in order to fulfill this duty is not well articulated. And the amount of risk that clinicians are expected to take in pursuit of fulfilling the duty is also not well articulated. And it turns out that other people sort of have this take from about the duty to care as well. This is some empirical data about what clinicians think their duties are in times of crisis. So not a normative analysis per se, but people asking clinicians, what do you think your duty is? And it turns out that clinicians do accept the duty to care. but there is some professional variation in the acceptance of it. So in a survey done of British healthcare providers after H1N1, people were asked to agree or disagree with the statement, doctors and nurses have a duty to the sick despite risks. Over 1,000 people participated in this survey, and the researchers found that there was variation by profession in terms of how many people agreed with the statement. Agreement was actually lowest among nurses. 70.8% of nurses expressed agreement with that statement, and agreement was highest among healthcare management personnel. 79.5% of healthcare managers agreed with the statement that doctors and nurses have a duty to the sick. Doctors were somewhere in the middle, but these were significant differences by professional role in terms of whether they agreed with this statement. We also see that there are cultural and regional variations in the agreement that there is a duty to care. This was another survey study done among nurses in both Spain and Chile during COVID. And nurses were asked, and this statement was a little bit different. Nurses were asked to agree or disagree with the statement, doctors and nurses have a duty to care for the sick, even when there are high risk to themselves or their families. So this was added in here for this survey. And there were differences between the Spanish and Chilean nurses in terms of agreement with this. Among the Spanish nurses, 81.1% expressed agreement, but among the Chilean nurses, only 71.9% of nurses agreed. So there were some differences by region there. And the authors of this study thought that it might have to do with the traditional family structures in these two different countries. Among Chilean families, it is more common for families to live in multi-generational households. And so it is possible, not proven in this study, but it was possible and hypothesized that maybe that specific inclusion of the risk to the families may have influenced Chilean nurses in a way that it did not equivalently influence the Spanish nurses. And finally, we see in the literature that clinician acceptance of the duty to care is also risk dependent. So this is a study that was conceptually similar, but contextually different of American physicians after 9/11, examining willingness to care for patients in the event of a bioterrorist attack. Over 500 physicians participated in this survey, and the authors found that willingness to take care of patients in the degree of a bioterrorist attack decreased among physicians as the degree of risk was both specified and increased. So 80% of physicians indicated a willingness to care for patients in the event of an unknown but potentially deadly illness. But when that illness was specified to be smallpox, the degree of willingness to care for patients in that setting decreased to less than a third of physicians said, yes, I will take care of those patients. So lots of different variation, both contextually and by other factors in clinicians' own expressions of willingness to assume risk to care for patients. There's comparatively less literature available on what the public thinks about the clinician duty to care. So I offer this bullet point with the caveat that all of the data here comes from a single study that I was able to find of Canadian non-clinicians after H1N1. And it was a focus group of about 30 people. And the public, those members of the public also said that they felt that clinicians had a duty to care, but they noted that there were legitimate limits on that duty, such as competing obligations. One of the focus group members in that study said that a physician isn't going to be any good at work anyway if she's worried about her kids at home. So there were both theoretical and perhaps practical thoughts that members of the public were including in their assessment of this. And there were also legitimate expectations that clinicians could have as they fulfilled their duties, one of which was a safe working environment, sort of hearkening back to that discussion of PPE that we had earlier. Appropriate compensation for their labor, both in terms of wages and also if they were hurt or killed in fulfilling their duty to care. Participants indicated that their families should receive compensation for any loss or disability that they incurred while taking care of patients. And finally, and interestingly, in my opinion, there was additional support that these members of the public indicated clinicians could reasonably expect, such as first priority for things like prophylaxis or vaccination. Those kinds of things were discussed pretty extensively, I thought, in COVID-19, but it was not terribly controversial among these participants in Canada after H1N1. So I mentioned that in this setting as well. So this then brings me to my work. And I really wanted to understand what the balance was for people in terms of their considerations, their duties, what they were morally obligated to do and not do as they made the decision to quit their jobs. As I mentioned, this is the start of this work. So I currently have completed 6 interviews, half and half women and men. It is a multi-professional sample, but it was a convenience sample. So they're all pediatric providers because that's who I know. And 4 of them were pediatric critical care medicine. However, it was really important to me that this not be perceived as a University of Michigan problem, right? I didn't want to interview people who had left only one institution because I really wanted to get a sense for some global aspects of what people were thinking as they made this decision. So 4 different institutions were left among these sample participants. 5 of the 6 remain in clinical practice in some capacity. Oh, there we go. And so with the analysis of the data that I have so far, I coded these interviews line by line and found 58 codes, which I have grouped into 6 themes as a preliminary analysis. 4 of these are competing moral duties. So to use the same terminology from the Canadian study, competing obligations that clinicians have in addition to the duty to care. A 5th theme was the inability to fulfill the duty to care for patients because of either institutional or other constraints. And then the 6th one is what clinicians are owed, what we can reasonably expect as we fulfill this duty. Finally, I don't want to say that thematic saturation has been achieved. I do intend to interview more people from more backgrounds, which I'll talk about more towards at the end. But this is where I am so far in terms of data collection and analysis. So with that, we will move to our first theme, which is the duty to family and loved ones must be balanced with the duty to care. And some of the things that participants talked about under this moral duty was work-life balance. Participant 4 commented on their children. I've got 4 children at home, and the idea of working 5 days a week with shorter shifts was a thing. Participant 6 also thought the need to be home with their children was important. I started thinking about my family. My kids are getting older, and weekends are getting more precious. Being physically present wasn't enough, though. People also had to be mentally present in order to truly achieve work-life balance. Participant 3 noted that after quitting their job, I come home and I lie on the couch. I'm not thinking about something. I'm actually just present. I can come to work, I can complete my job, I can do a good job, I can leave, and I don't have this lingering of those patients and their worries and their concerns in your soul. Participant 5 noted that their preoccupation with work actually prevented them from talking to their family for a long time because, quote, all I had the emotional capacity to do was go to work and take care of these kids. And then I would come home and I would just crash. The duty to family also kept people in their jobs, though, too. It was a compelling reason for some individuals to stay. Participant 2, who's the only participant to no longer be in clinical practice, noted that they had multiple healthcare providers in their family. My grandfather was a doctor, my dad is a doctor, my mom is a nurse, my aunt is a doctor. And I worried before my grandfather had passed what he would think when I quit. He was a doctor's doctor, like back in the day. And I think that one of the things he was most proud of about me was that I had become a doctor. Ultimately, though, concern from family and loved ones really alerted people that it was time to go. I think this slide really segues nicely into the next competing moral duty that participants expressed balancing with the duty to care, which is the duty to self. We saw work-life balance come up as focused on the self as well. Participant 1 noted that they were able to achieve work-life balance with less guilt than at their previous job, because at their previous job, quote, it always kind of felt like you owed something to the hospital to your during your off time. Mental health was a huge issue for participants who had quit. The next couple slides are all going to be associated with this theme of mental health. And participant 5 commented on this really poignantly. Someone said to me, if all our good nurses are just going to keep leaving, then who's going to take care of the kids? And I was like, listen, who's going to take care of me? I already had to start going to therapy again because of this job, and I can't afford to go twice a week because they don't pay me enough. Participants also talked about some of the mental health issues and maladaptive coping mechanisms that they saw in the people around them, in addition to talking about their own mental health concerns. Participant 6 described a story of one of their colleagues. One of my colleagues said he started smoking. He hadn't smoked in 15 years. I started smoking again. He said, why did I do that? It's because I couldn't take it. One of the things that was really hard to take is trauma. As you might expect, COVID brought with it a lot of trauma. Again, participant 6, I had very traumatic experiences, one right after another, that affected me in a completely different way than it ever did before. And I realized I couldn't do it to myself anymore. I didn't want to do it to myself anymore. Participant 3 noted that even among ICU providers where this trauma is somewhat expected, right? We go into our jobs expecting that sometimes, despite our best efforts, patients will die. That didn't make it any easier. They described a patient who had died and, quote, I was at home, somebody called me and I started crying. My husband looked at me and he goes, but you knew he was going to die. Like, so in his world, well, aren't you prepared for this? Like, this happens and you do this. And I'm like, it still doesn't make it any easier. Some of this trauma was so significant that participants actually described a loss of their sense of self. Again, from participant 3, quote, you don't even realize that you're just not living in your own life. You're just like, there's always something gnawing at you because of what you've been through. Participant 5 said, all I ever did was think about work. If I wasn't at work, I was thinking about how I should go to work. And finally, participant 2, there came a point where I could no longer separate whether what I was doing was something that I had come up with and really liked, or just something that made other people happy. It's still something I'm trying to learn how to do, to learn to internally validate and think that I'm doing a good job, and therefore I'm doing a good job because I think so. This next slide describes the duty to colleagues. Every single participant I interviewed with described worrying about what their absence would mean for the people who they left behind. I'm not going to read it because I choked up every single time I practiced it. So I'm going to let you read in your own words what these people went through with the people who are working alongside them. Finally, the fourth competing duty that people described was a duty that they felt to the future. Specifically, trainees and junior colleagues were mentioned. Participant 1 commented that I would say the training program at my previous institution knew how to put a square peg through a square hole, but they didn't know what to do with a round peg. I was a round peg, and in about every fellowship class, there was a round peg, and that person was ostracized and made to feel very small. At the time, they had maybe 3 or 4 out of 20-some faculty members that they could go to, and I was one of them. Now they have less than that because 2 of us have left. Participant 3 said, it's hard to see the young nurses come in. It changes who you become. At least I think it does. And how do we prepare them? You're going to face the worst things in the world. And in addition, people worried about the abstract concept of the future of healthcare. Participant 5 said, I think this is a really important thing that I would like to see people understand. The nursing shortage and the doctor shortage, nobody wants to do this anymore because they've made it so completely untenable. In a really telling comment, participant 3 commented, I don't want my daughter to be a nurse. I talked her out of it because of the bullying and the trauma. I think this quotation is really worth thinking about in the context of duty to family as well, what we owe our family members. And again, I think this particular quotation is very telling about some of the difficulty that these providers went through in their jobs. Finally, we're going to come full circle and talk about the duty to patients. And in a second thing that was really surprising to me about this project is that the inability to fulfill this duty is something that caused participants tremendous distress and drove them away from the bedside. One of the things that kept people from being able to fulfill the duty to patients was unsafe staffing. Participant 5 said, every single day, I was scared that a child's going to die and it's going to be because I could not provide safe care. And that's the reason I left. I left because every day I drove home and I cried because I knew that I provided halfway nursing care to at least one of my patients. People also didn't want to be complicit in institutional wrongdoing. Participant 1 told a story of putting a pick in somebody inappropriately, like put it in the wrong patient. And I was told that there wouldn't be a root cause analysis because the pick had been a successful placement, even though it was in the wrong patient. So no harm had been done. Some of you guys may have seen in the New York Times a couple of months ago, there was an editorial that talked about the difficulty that clinicians have essentially shilling for the capitalist machine that medicine has become. That if you haven't seen it, you should really go read that editorial. It's really quite good, by a physician named Eric Reinhardt. And this came up in my research too. People felt that things were too focused on the money at the expense of good patient care. Participant 5 noted that pre-COVID and post-COVID, their hospital was not the same. And it's because their priority was the money. And finally, especially among my ICU and former ICU participants who got into their jobs to help people and save lives, feeling like they were only causing harm and prolonging death was a really difficult transition for them to make. Participant 6 said, I just saw it over and over. You're waiting a month for a decision to be made. I couldn't sit through that anymore because what I was having to do then for another month was just torturous. No one would say, I'm so sorry, but there's nothing else to be done. But it has to be said. Participant 3 noted the unique perspective on patient care that nurses who are at the bedside so often have compared to physicians and other clinicians who often come in the room and go. Quote, when the nurses in the room are telling you this is not okay, that is the biggest red flag. It is so different when you come in there and you talk to the patient or the mom and then you leave, or you're in there 12 hours wiping that kid's ass. And when you are not listening to all those nurses who are in there for 12 hours, you are missing the mark. And finally, participants described the difficulty that we had with families and the COVID visitation restrictions. As Naomi talked about in the introduction, the visitation restrictions were really something I was really heavily involved with. And it was clear that this affected other people as well. Participant 6 commented, I personally was told by my manager that I had to tell a parent that they had to leave. And I looked her in the face and I said, I absolutely will not be doing that. That experience is burned in my brain. I think about those parents all the time. Finally, the last theme that I want to talk about today is what are we owed as we fulfill this duty? Personal safety, I think, is probably pretty obvious given the subject matter that we've talked about at this point. And I think in what I think is a really concise representation of acceptance of a duty to care with some limits, participant 5 says, yeah, I'll go in and take care of the scary new virus that we've never heard of because I did sign up for that, but I did not sign up to do it in a bandana. Compensation was mentioned as well, again from participant 5. My first raise as a nurse was 10 cents. The hospital administration were like, well, it was difficult, but we still made it work. You will still be getting your raise this year. And we were like, I think it was more offensive to do it that way. Equitable compensation mattered as well as equal compensation. Participant 1 said, without getting into finances, we had a pretty significant productivity bonus. And what we came to find is that the productivity bonus varied with no real transparency as to how. It was pure favoritism, in all honesty. It didn't need to be that way. Psychological safety, in addition to personal safety, was brought up as well. Participant 2 says, you get into medicine and you're told it's unreasonable or unseemly for you to cry, to break, to feel broken up about something, or to think about something for too long. The people who do the best, they have the strongest walls put up, right? Participant 1 commented on some global issues within their department. There was an incredible amount of racism and sexism. I felt like my previous institution said all the right things, but when it came time to actually acting, there was much less weight behind their actions, behind their words, than behind their words. And finally, like anyone, people wanted to grow in their careers. Participant 4 commented, I never really felt like the expert on many things. It's not to say that I didn't know, but I felt like, oh, you're the new diabetic or newly diagnosed with diabetes. Well, then let me get endocrinology here. Participant 2 talked about support for their research. I felt like I had developed a niche that was lacking but desirable, and I would get both support and also some autonomy. But as it's often the case, despite being halfway through writing a K, I couldn't get sign off from my division. So what's next? One is that I think it's pretty clear from the information and the data that I've discussed so far that there's a corresponding institutional and organizational duty to care that exists alongside the duty to care of the individual clinician, and I would like to explore that further. One way in which I would like to do that is by expanding the sample of people that I talk to. There's no leadership perspectives in here. I would love to hear from institutional and organizational leadership about their perspectives on some of these data and what they think they owe to the clinicians who work for these healthcare organizations. I'd also like to get more types of clinicians included in the sample. There aren't any primary care providers, for example. I think the outpatient perspective is something that's really vital if this is going to be a complete project. And I also think, we talked about a lot about the pandemic and how the pandemic impacted the clinicians who spoke to me for these initial interviews. I think in a lot of ways, OBGYN is having its pandemic moment right now. And what abortion providers are willing to do and willing to risk in order to care for patients is an analogous question that is really worth exploring within the context of this sample. I'd also like, along those same lines, I'd like to really expand what the risks of the duty to care include. A lot of the information or the arguments about the duty to care come in the context of pandemics, right? Communicable disease as the risks that clinicians take when they undertake this duty to care. But I think that there are a lot more than that. And I think that's clear from the data here. Burnout, attrition, legal risk, as I alluded to when talking about OBGYNs, all of these are additional risks and need to be explored, as well as the risks that clinicians take in terms of infectious disease. And finally, long-term, I'd really like to look more at moving from the duty to care as a concept to an ethic of care within healthcare in terms of us taking care of patients and institutions taking care of us. And that's one thing that I would really like to emphasize as we finish up here. One thing that I think that we can do differently starting tomorrow, today even, is that we as healthcare providers can take better care of each other. Participant 3 talked about how difficult it was to not feel that way. When you're laying your soul on the line for a family and the team doesn't rally around each other to support each other, it's really, I feel like, a double whammy. Participant 2 commented that nobody ever says, oh, that person cried after this really difficult encounter. What a brave, strong person to have done that. We sort of, for our own protection, we say they're just too emotional to handle it. And participant 6, experienced this firsthand. They said, quote, some people would blame me, like, oh, why are you taking these patients then? We can take better care of each other. And I think, again, we can start doing that right now, today, as we work on fulfilling this duty to care, which is so necessary and demanding, but also so satisfying and so fulfilling at times as well. I'd like to end on a high note. I talked about a lot of really difficult things and a lot of really intense things that people went through, but I do want to let people know that everybody is doing okay. And finally, I want to say thank you to Dr. Fern, who has been my mentor for this project. She really only signed on for 12 months while I was doing my master's thesis work, but I guess, one, thank you, Janice, but two, I don't intend to stop bothering you about this project just yet, so I hope that that's okay. Dr. Hanto, who may or may not be on the line, I hope he was able to come today, but he was my seminar mentor and helped me shape this project from the very beginning. And finally, of course, I really want to thank the folks who interviewed with me for this project. I think that healthcare heroes is a term that really was overused during the pandemic. We heard it a lot, the healthcare heroes. It was on every yard sign. But I think that you can see that these folks really gave something of themselves, much of themselves, a lot of the time, to take care of other people during a time of what was really global crisis and upheaval. And I am really humbled that they were so open to sharing with me through these interviews, and by extension to sharing with all of you here in this Zoom room today. So thank you very much for your willingness to share. Certainly, I will take questions if folks have any. And then I actually brought some questions that I have for the folks in the audience today, because I do have some things that I want to do with this project. So if nobody else has questions, I got some questions that I hope we can discuss. But by all means, any thoughts, comments, questions, I would love to take.
Well, Dr. Andrist, thank you very much. That was very thought-provoking, and I think what a very nice turnout to this presentation, which I think speaks to what a broadly important and interesting topic this is. So I see hands raised, and do I have the ability to unmute people and let them speak in, Amy or Emily? I'm not sure that we were able to do that.
Oh, not in a webinar.
Okay, so we're not able to let people unmute and speak. So if you have questions that you want to populate into the Q&A, please do that, and I'll get to as many of them as I can. And while those come in, and I might ask Kate to look at them with me and help me prioritize these a little bit, but I am going to take moderator privilege and ask one of my own, which is, in thinking about this, you've been deep in this and thinking about phenotypes of people who leave. And I know you've only spoken with 6, but we can step back and think at a systems level. We don't want to have people leave the profession. It hurts us in a lot of ways. And we think about the financial cost and the opportunity cost, but maybe for some people leaving is the right thing. And what comes out to me in your data, I think, is that some people leave after sort of an inflection point that allows them to reflect and say, maybe this isn't what I expected, or it's not what I wanted, or I don't like it, versus people who are broken and who leave because they can't continue. Does that ring true to you? And can you identify people who leave where we can say maybe that was right for this person, as opposed to we did wrong by this person?
The short answer, Naomi, what a great question. The short answer is that I would say yes. I think that in some cases leaving may be the right thing. And I think some of the information on the recovery slide speaks to that. However, I would also say that it was not most people's first choice. And people tried other things to avoid leaving, or commented that they wished they would have had access to certain other things. Like one thing in particular would be a participant who commented on wishing that she could drop her hours to have more time to recover and more space between the traumas that they were experiencing. But financially that was not possible. And so the only alternative that they felt was available was to change jobs. And so I think that we can incorporate the need for people to have time to recover, to have some space to decompress and emotionally recover from the trauma that they're experiencing. That doesn't necessarily mean that they leave permanently.
Thanks for that. There's some comments and questions that I'm going to address from the Q&A. One is from our own Dr. Lozon, who I think is inviting you to engage on this topic, saying, I'm one of the leaders who would be very happy to discuss this. I think there are complex generational and discipline-specific issues that are difficult to generalize. And later on, there's a question about whether, in your sample, do you get a sense that there's a generational divide here, or are you picking that up as you learn more about this topic?
Yes and no, I would say. I think that the human heart can fill up bit by bit or all at once. And so I didn't describe ages, but there were some really young folks in their 20s who interviewed with me for this project. And there were some older folks who have been doing this for 20 years who interviewed with me for this project. And so I think that the reasoning may be different, whether you were thrust into this during the midst of COVID-19 versus if you've just accumulated the trauma of this over the course of many decades. But I did not encounter in the limited sample of people that I have talked to a really substantial difference in the ultimate outcomes for how people were feeling and how people processed that trauma between participants who were older and who were younger. And yes, Dr. Lozon, if you let's talk. I really would love to talk with people in administrative and leadership positions, because I think if ultimately this becomes something that will result in policy change, because as Naomi said, right, like this costs us not only individually, emotionally, like we've talked about today, but financially among institutions as well, in camaraderie and morale among teams. Like I would love to see this have positive change at institutional levels.
Thank you. These are coming in quickly now, and so I get the prerogative of getting to sort of choose among them and also prioritize the one that are in front of my eyeballs first. But there's one about whether people brought up the issue, and it probably depends a little on the timing of when you were doing these interviews, about whether public COVID denial or other themes like that, sort of the public response to the pandemic, impacted people's experience of it in healthcare, and whether that came out in your interviews.
Not in my interviews, no. And I agree. I was a little bit surprised by that, but I also wonder if a large part of that is because pediatric providers were the focus of this sample. And I think true COVID denial was really more, I suspect that was really more commonly seen among adult COVID ICUs. So that may just be one of the many limitations of my small current sample size.
Thanks. For folks with questions coming in, I'm trying to get as many as I can. Erica, there's a question about the role of talking with people who stayed, and whether there's something to be learned from sort of comparisons and looking at folks who didn't leave.
Yeah, people who are like on the verge of leaving, but decided for whatever reason to stay. Yes is the short answer. And I think there are two populations of people that are important in that group of people who stayed. One is, as I started, people who really wish they could have left or want to leave, but for a variety of reasons didn't, or perhaps can't, for financial reasons or whatever the case may be. How do they cope? And then the other group is people who are really doing great, right? There are folks who aren't burned out. Sometimes it doesn't feel like that, but the data would indicate that there are. How do they do it? What's protective? What can we look to from people who are really thriving in an environment like this to help it be more globally applicable to people who are struggling? And people can struggle, I would say, too, in intermittent times or more long term. And so what are strategies that we can use to bring people back from a prolonged period of dissatisfaction, of burnout? And when, for people who are just having a rough stretch, can we employ either the same strategies or other strategies to help bring them back to a place where this is something that's really feeling fulfilling? Because I think a lot of us in any job, healthcare isn't unique in this regard. We have our ups and downs, right? Some days are really hard and some days are really good. And so how do we keep some sort of, not balance, but levelness over the course of a prolonged career for folks as they evolve?
Thank you. One thread that you brought up that was that came to me through the questions was this issue of the ability to leave as possibly a luxury. That's something that if you have financial flexibility, if you have a partner who can support you in leaving, have you thought more about that and thinking about that? Who has the option of quitting?
I would say the short answer is no. Well, let me back up. I've thought about that, but I haven't done anything about that with it yet. But I agree. I really worry, frankly, about that population, right? One thing I didn't talk about in this presentation, but I think is sort of on the dark underside of things of burnout and well-being, is self-harm and suicide, which is high among healthcare providers. And that is a population of people that may not have access to quitting, there is a population of people who may not have access for whatever reason to quitting, but who may need to get out, and for whom that may become an option that becomes more considered. And so I do think that teasing that out is something that's really important.
Thank you for bringing that up. That was actually a topic of a question that was in the chat. So you beat me to it on that one, but I'm glad you're thinking about that important dimension of this as well. It's kind of the most hair-raising of them, I think. There's a question about the role of medical students and whether we shelter medical students from this, whether that's good or bad. I know you didn't work with medical students in your sample, but you talked a bit about that future-facing component of this. What are your thoughts about the role of students in things like a public health crisis? It's something we talked about a lot during the pandemic.
I guess I haven't thought about the role of students in. I have thought about it mostly in the context of a protective role. And so I guess I don't think probably this is really what the question is getting at, but I will share the thoughts I have had related to trainees and medical students. And maybe I can think about this more and follow up afterwards.
It's a time-honored bluff, Erica. You get to do.
But I do think we need to be open about how hard this job is. This is a thing that some of the participants talked about as well, but we really don't often have a willingness to be open and vulnerable about how emotionally challenging this work can be. We share the victories and the confidence and the good parts, and we aren't always as open with the hard parts. And so I think that sometimes hits trainees by surprise. Speaking for myself, I as a critical care attending, I spent a long time coming up to attendinghood thinking, as the brand new first year fellow, you're like, okay, if I get through my first year and then I get to senior fellowship, then I won't be scared anymore. It won't be hard anymore. And then you're a senior fellow and you think, at least I thought, okay, well, I'll finish fellowship and then I won't be scared anymore. It won't be hard anymore. I'll start to get it. And then you get to attendinghood and you're the scaredest you've ever been. And you think, well, once I get a little bit of experience attending under my belt. And so realizing that we all have these really difficult moments and these really difficult feelings that we're all trying to process and deal with, I think is something that we could be more open about, because it normalizes it. And so I think that, especially if we're going to be of the argument that clinicians consent to taking these risks, we have to be open about what those risks are. And so that, I think, when I think about medical students, that is one thing that we can do to help sort of bring them into this fold, which again, I think is probably not the actual question that you were asking, but those are sort of the thoughts that I have had in regard to medical students and trainees.
I mean, I think it is. It's kind of a rich and thick is the thick description of that concept of sort of how we protect people from this. I think it's nice to see that you've given that some thought. There are a couple of questions we haven't gotten to, but your slide here is I'm finding a little tantalizing. So I think we need to see what these questions were that you had on this slide.
Sure. So I'll go
come up.
I'll go through all three real quick, and then if folks have comments on any or all of them, love to take those, or happy to focus on your questions as well. One is, who needs to be sampled? I've talked about some of the specific populations that I feel like I would like to actively recruit, but I'm sure there's somebody I'm missing. So if folks have ideas for that. I don't know what the final form of this project is going to be, right? We do research thinking about, like, ultimately I'm going to write a manuscript, but I don't actually know if that's where this is going to go. Talked about the realm of sort of policy making. A book for public consumption is a thought that has crossed my mind. I hesitate to even say that out loud, but it's a thought that I have had. But if that's the case, then question number 3, this was a really intimate look, right, into the mental health of clinicians. And are there potential untoward consequences of the public, of potential patients having such an intimate look into where clinicians are right now? So those are some of the questions that I've been thinking about that I would love feedback on from anyone who cares to comment.
Well, one person saw that question coming, and there's a comment in the Q&A about the role of primary care providers in this zeitgeist and their experience, and a speculation that it's in a lot of ways pretty similar. And I think that's something we heard, particularly thinking about PPE and sort of, in pediatrics, for example, where, kids are in pediatrician's office with URIs all the time. And when all of them were PUI, right, in the peak of the pandemic, and what that meant, and when there was insufficient PPE, or when you found out when they were already in your exam room and they weren't all suited up that, oh, by the way, he has a sore throat or things like that. So I think that suggestion of getting out of the ICUs is one that you've been given.
Absolutely.
I would imagine in your field too, thinking about things like beyond nurses and physicians, but respiratory therapists, and the whole gamut of professions that it takes, the village that it takes in an ICU to care for these patients, and all the people who go in and out of those rooms. I'm not seeing anything else come in, but you've certainly given us, I think that last question is in particular, I'm finding to be really, that's going to leave me, I think, churning for a bit, is it's always this, what happens when you show people the underbelly, right? And does it foster compassion in us? Does it undermine our credibility, or does it make us more relatable as humans? I think is going to be a really interesting question, but I think we're all looking forward to seeing you forge ahead with this. And following this work with interest, whatever final form it takes. So thank you very much for taking time to share your really compelling work with us. And we look forward to hearing more from you.
Thank you all so much for your questions. And you've certainly given me a lot to think about as I move forward with this. So thank you all very much.